Thank you.
Yeah, thank you. So today, we're going to be talking about asthma education. This is a very important topic. Um, Here, my goal is actually to empower stakeholders. We are all stakeholders in asthma management, so it's good to empower all of us on how to manage asthma, how to manage our patients. On if you're a parent here or a caregiver, how to actually manage asthma at home. And if you're a policymaker, and I hope there's somebody, at least one policymaker here, how to talk about or advocate for asthma management wherever you are. So a little disclaimer. I always have a disclaimer. First of all, the information provided in this session is for educational purposes only, and it is not intended for medical advice or asthma diagnosis. Consult your healthcare provider or asthma specialist before making any changes to your asthma management plan. And if you're experiencing any changes in your symptoms or concerns, you seek immediate attention. Okay. So, learning objectives for today will be first pathophysiology of asthma. We want to also learn the statistics on the prevalence of asthma, update on current asthma guidelines by Gina, effective use of medications and inhaler techniques, health worker role, which is our role in managing people with asthma. Okay. And I have a quote. I usually start out with a little quote, and it is, give a man a fish and you feed him for a day. But if you teach a man to fish, you feed him for a lifetime. But the thing is, you cannot give what you don't have. So you can actually teach your patients if you're not empowered. Okay. So you cannot advocate for your patients if you're not empowered. So today it's all about empowerment. Okay. So we want to be empowered enough to teach our patients how to manage themselves at home. Because trust me, the problem is not really when the patient comes to us in the healthcare facility. There they have, all of us, they have respiratory therapists, they have the physicians, they have nurses. The problem really is when they are outside of the walls of the facility. How do they manage themselves? Do they actually know what to do? So we are here to empower each other, if you're a healthcare practitioner, to be able to help our patients. So, 4 goals. My goal for this presentation is first for the healthcare professionals who are here, because I understand that this audience, people are still logging in, but the audience comprises of health practitioners. We have students. We can have, I believe we'll have patients and also maybe caregivers or parents. And I'm hoping we have policymakers here as well. So for healthcare practitioners, this is to help us to understand the latest guidelines in asthma management using GINA guidelines. And if there are any students here, is to understand the disease and its management. For the patients and the caregivers that are also logged in here is to know how to manage your conditions and make informed decisions. And for the policymakers to understand the impact of asthma and how to support its management in schools and community. So a question I want to start out with is, have you ever imagined what it feels like to struggle with breathing? If you have asthma, if you have any other, lung disease or problem, then you will know. But I don't have asthma, so I can't even really tell you that I know what it feels like. But I have, tried to imagine it. And what I did was to run up the stairs. After running up the stairs, I had a little straw in my mouth, pinch my nose. I'm trying to breathe through the straw. And, at the end of the flight of stairs, I was out of breath, I was trying to catch my breath. My heart rate was so high. My respiratory rate was really high. And this is just a control. It was a controlled environment because I was controlling it. I can tell you that it wasn't easy at all. Like I started to cough and I just released my nose and I started to breathe. Now you can imagine, what about that person that is in an uncontrolled environment, right? That person with the asthma that is trying and struggling to catch air, to get air out and to bring it in, is difficult. So I do have, I want us to hear from somebody with asthma just in 1 minute. I believe Robin, if you're here, you can unmute yourself. Robin is my friend, is a co-worker. She's actually a respiratory therapist, but she has asthma. I want her to draw us in a little bit, just in 1 second, what it feels like when you're having an asthma attack. Robin, are you there? Maybe not. Robin? Okay. All right. So we'll continue. But I guess she couldn't make it. So, all right. So, but anyway, I want us to really start imagining this, and that way we can take care of our patients better. All right. So the word for today is actually empathy. Based on what I've just said, the word for today, and not just today, but whenever we go into that hospital or wherever we work, or to take care of our patients, the word is empathy. Empathy is when we actually put ourselves in the person's shoes and just kind of get a little glimpse or a little bit of what they might be going through. Okay, so now I'll jump into the beginning of the lecture, talking about asthma. I don't want to assume that everybody here knows what asthma is, because we might have students here and maybe some parents or caregivers. So asthma is a chronic airway disease. It's characterized by inflammation, bronchoconstriction, and airway hyperresponsiveness. It's really prevalent worldwide and is increasing. According to Hodgkinson, he predicted a 400 million increase by 2025, which is this year. And I can tell you that I see that happening because I'm actually part of, I joined the asthma support group. And every day, somebody is joining with a new diagnosis of asthma. Somebody, these are like adults in their older age, 50s, 60s, just diagnosed with asthma. And I also work in the asthma clinic, and I hear the patients talk about, they just got diagnosed with asthma. So I do see the prevalence, and I do see how it's going up, how that can be possible. Now, in this picture, this picture here shows a normal airway on the left-hand side. This is a normal airway, right? Air goes in and out through the lungs, in and out, freely, no obstruction. It's nice and open. But when there's an asthma attack or an asthma airway, there's inflammation. There's inflammation. The airway is so tight. There's a narrow hole from which air is trying to pass through. And through that hole, narrow hole, that's where you hear the wheezing, because air is trying to get through the narrow hole. They are coughing, there's mucus production, and then there's constriction of the smooth muscles. So all these things are going on. The patient is trying to catch their breath. So that's how asthma, attacks, or what happens in the lungs, on the airways when there's an asthma attack. So now when there's an underlying inflamed airway, which an asthmatic airway there's always that inflammation, a little bit of inflammation in the airway. Is just waiting for a trigger. It's just waiting for something to set it off, and all of a sudden things start to happen. So when an inflamed airway meets a trigger, all the mediators are released. The leukotrienes, histamines, eosinophils, they are all released. And these are the body's normal way of fighting an infection or fighting any allergen. But the problem is they also cause inflammation and constriction. Okay, so it's like one invites the other, and everything just, they're just doing their thing, but while the person is suffering. So some of the signs and the symptoms that we can see with asthma will be things like shortness of breath, wheezing, coughing, chest tightness. You can see retractions, especially in children, mucus production, nasal flaring, labored breathing, and then nighttime awakenings. Okay, so a lot of times some people might wake up at night choking or trying to breathe, trying to catch their breath. They're out of breath at night. Sometimes they wake up earlier than usual, trying to catch their breath. So, and the types of asthma would be, first would be allergic asthma. There are some people that just have, it's allergic asthma. So whenever they come close to anything that they're allergic to, that triggers the asthma. Eosinophilic asthma is also when the numbers, eosinophils, which is a type of white blood cell, is increased, right? When it's increased, it's also, it leads to inflammation of the airway. So, and there's exercise-induced asthma. For some people, it might be when they are, exercising or physical activity, because the normal way that we breathe, even, normally we breathe in through the nose, right? But during exercising, we all are forced to breathe through our mouth. And our mouth doesn't have that normal, what's it called? The mediators or the things that will kind of keep the allergens away. Okay, so the filter, it doesn't have the filters like the nasal, right? So that can cause an asthma attack. Cough variant asthma. Then there was a healthcare practitioner that one time told me that she never knew that coughing was actually, a sign or a symptom of asthma. There are some patients that actually the only symptom or the only sign that you will see is coughing. It's called cough variant asthma. So they're just coughing constantly, So eventually there might be wheezing or other things, but it's only coughing that they can experience. Okay. So nocturnal asthma is also asthma at nighttime. With the nighttime awakenings, people wake up at night or in the middle of the night or very early in the morning, not because they just want to wake up, but because they are struggling with their breath. And then occupational asthma will come with, where we work. If we're exposed constantly to occupational hazards and things that can trigger asthma, then, that causes asthma attack as well. Some of the triggers will be irritants. There are irritants, which are perfumes, cleaning products, tobacco, wood smoke, chemicals, air pollution, aerosol sprays. So I do want to also really stress on this for healthcare practitioners, for us, right? We have to be mindful of what these patients are going through and what they are actually allergic to or sensitive to. Sometimes some of them might be sensitive to perfumes, the perfumes that we wear to go to work, right? I've seen that happen so many times, right? And then there was, I think this one happened last week or 2 weeks ago at the asthma clinic. The patient was brought to me to the clinic, but the lady, when she came to me, she was coughing. She started to cough uncontrollably. Now, she already knew what triggered that asthma because somebody from the front desk wheeled her. She was in a wheelchair, wheeled her to me, and that triggered her asthma. She said the perfume that she had on was, too strong. So, and she started to cough. But thank God she had her inhaler with her. She used it right there and everything was all good. Now you can imagine what if she didn't have her inhaler, right? We would have been calling maybe a code or something on her. So we have to be mindful as healthcare practitioners that we are not actually the cause of the problem, or we are not the triggers of that problem, right? We are there to treat and not to cause more harm. So it's just to bring that to our awareness. And then you have allergens like animal danders, dust mites, cockroaches, mold, mildew, grass, weed, pollen, dust, right? Physical conditions like viral infections. Infections can trigger asthma. Exercise, weather changes, emotions can also trigger asthma. Medical conditions, like some people with reflux, gastroesophageal reflux, that can also make asthma worse or trigger it. Sinusitis, rhinitis, sensitivity to beta blockers. Beta blockers are medications that are used, for like cardiac patients and things like that. From the name, it's actually beta blocker, and then that actually blocks what the bronchodilators the asthma patients use, right? It kind of blocks the action. So it's also good. It's always good to make sure that the patients are following up with all their doctors, actually, if they have a cardiac history, or if they have, asthma, and then all the things that, they know that the physicians are aware that they have asthma and, work around it. So these are the things that can trigger asthma. Some of the causes of asthma, according to the World Health Organization, asthma is more likely when other family members have it. Asthma is more likely when people with people with allergy conditions. Then urbanization is also associated with increased asthma prevalence due to air pollution, poor nutrition, reduced activity, and exposure to allergens. And also there can be events, when early in life, when the lungs did not develop fully, as babies, the lungs did not develop fully, and maybe smoking around, when a woman that is pregnant or smoking around the child, that can also, cause or lead to asthma symptoms as well. And some of the risk factors would be poverty, air pollution, access to specialist medical care, pollen counts, medicine use. So a lot of overuse of the short-acting beta agonists, and not enough use of the steroids, controller medications, tobacco policies, and the rate of uninsured residents. Okay, so if you're in a country where there's we use insurance, like here, there are some patients as well that do not have insurance, so it's also difficult for them, right? So, I hear a lot of people say asthma is just asthma, right? It is not just asthma. Asthma is also one of the non-communicable diseases. Non-communicable diseases are these diseases that they're in the same category as what's it called? COPD, diabetes, cancer, heart disease, right? Asthma is also there. So asthma is a major non-communicable disease that affects both children and adults. This according to the World Health Organization. And in 2021, 18 million people died from non-communicable disease before age 70 years. And 82% of these premature deaths occur in low and middle income countries. I highlighted it in orange, okay? And we'll see it again. So here, I just put this slide here. This is just for the US actually, but I kind of wanted to, show us a little bit of, what we are looking at here in regards to asthma prevalence and morbidity and mortality. So if you can imagine, this is just the US, then you can now kind of imagine what it is in other countries or in low to middle income countries in Africa, right? So here, these are non-communicable diseases. And this from 2018 to 2022. So heart disease, cancer, diabetes, and COPD, and then asthma. I just circled the asthma, the ER visits, which is a lot more than the other ones. Could it be that it's because of maybe lack of education for the patients, or maybe even healthcare practitioners? Could it be that the patients are using the emergency room as their primary care doctor, that the first point of contact? Could it be is it because that they don't have an asthma action plan, and they immediately anything happens they run to the emergency room? So I don't know why that mark came here right now. Okay, so this is also the non-communicable diseases, right? And again, I circled asthma episode and attack and current asthma. It's just for us to see, this is the US as well, but it's just for us to see the trending. The other ones like the CAD, myocardial infarction, diabetes, COPD, they've kind of remained like between the 2021, 22, it kind of remained there stable a bit, right? But asthma actually is the only one that's been trending higher. The asthma attack went from 3.3% to 3.7%, and current asthma 8% to 8.7%. So it's trending up. Okay. So now asthma prevalence, according to the World Health Organization, asthma affected an estimated 262 million people in 2019 and 455,000 deaths. And most asthma-related deaths occur, again, in low and middle income countries due to misdiagnosis and undertreatment. And according to Yan, in this year, 2025, global prevalence of asthma is 9.1% among children, 11% among adolescents, and 6.6% among adults. Asthma is significant in low income, low middle income countries or areas. Now, they pointed out that childhood asthma in Nigeria account for approximately 1.6% of global burden, according to children and adolescents, among other. So now, according to the Global Initiative for Asthma, GINA, 96% of asthma deaths and 84% of disability-adjusted life years were in low and middle income countries. Okay, so I just put this here. This is a slide that shows the countries that fall under that low and middle income countries, right? And that is not all. If you look at it and you say, oh, I'm not there, my country is not there, there's more here, okay? And majority of them actually, African, sub-Saharan African countries. So we all have a role to play. Now, asthma burden, poorly controlled. When asthma is poorly controlled, it can lead to increased economic burden. This is for the patients, for the family members, for the community, for the economy, for the country in general. It can also lead to lung function deteriorating, going down. And when it's poorly controlled, it can lead to physical and emotional distress. It can lead to an asthma exacerbation or attack, and it can also lead to death. So it calls for action on all stakeholders. We are all stakeholders, healthcare practitioners, the patients, policymakers, family members. We are all stakeholders in asthma management. So a little bit of a breather. I'm sure by now you're pumped up to do things differently where you work. We're getting there in a moment. So this dog is ready to work. He has his tools, and we should too, right? So asthma management can vary, from country to country. There's always, the variation. Every country has its priorities. According to Wang, he said that some African countries are challenged with providing effective medications to asthma patients. And they also said that some certain Asian countries are challenged with strengthening the interpretation of asthma guidelines. And some Latin American countries are challenged with improving asthma patient self-management education. Okay, so from now moving forward, you hear me talk about GINA a lot. Now, GINA is it means what's it called? Global Initiative for Asthma. They are the ones that make the guidelines and the recommendations based on evidence-based strategies, right? They come up with the recommendations and the guidelines that we use in the management of asthma. So their goal for asthma treatment is to achieve the best possible long-term asthma outcomes for the individual patient. So which means long-term symptom control, long-term minimization of the risk of exacerbation. Okay, so the longer they can go, without having an exacerbation or attack or any kind of symptom, that would be amazing. Okay, so what is new for GINA in 2024 is the asthma diagnosis. Asthma is diagnosed usually, by spirometry pulmonary function test, right? But GINA understands that there are countries, low to middle income countries that might not, and they don't have this diagnostic tests available like we do here. So they also said, although the peak expiratory flow meter is not as reliable as the spirometry, but it can also be used instead of just relying on symptom alone, to diagnose a patient. Now, covariant asthma, like I mentioned before, there's some patients that will it's just coughing, Coughing is the only symptom that they might experience for a long time. So for those patients, their spirometry results will be maybe normal, right? So there's another way to test that one, and that's called bronchial provocation testing. Asthma control assessment. They also say that assessment of asthma control should not be limited to most recent 4 weeks because, on the asthma control test, that's what we usually use to figure out the level of control of asthma for each patient, right? So, but it's only asking in the past 4 weeks, have you experienced this in the past 4 weeks, So, but they're saying that it shouldn't be the only thing. Risk factors for this asthma exacerbation should be assessed as well. The risk factors should be assessed, okay, and must be assessed, actually. Okay, so that leads us to the treatment for asthma based on GINA guidelines, right? So this is for patients 12 years and above, 12 years and up. So if the patient is experiencing symptoms less than 3 to 5 days a week with normal lung function. So you hear some of the patients, with mild asthma, they tell you they don't experience the symptom. It may be once in, who knows, maybe once in a month or something like that. GINA recommends the preferred is track 1. They recommend as needed low dose. So ICS means inhaled corticosteroid. So steroid, I'll say steroid for short, right? So the recommended medication is the low dose steroid with formoterol. Formoterol is a type of medication, which is a long-acting bronchodilator. So the recommendation is the low-dose steroid plus formoterol. Now, also, the track 2 will be having a low-dose steroid whenever short-acting beta agonist is taken. Short-acting beta agonists would be things like the rescue inhalers, the albuterols, salmeterol, those ones. Those are short-acting beta agonists. So they can take that whenever, take the steroid whenever they take the short-acting beta agonist, right? Because they don't experience symptoms often, it's maybe once in a while. So that once in a while, when they are exposed to a trigger and they want to take their short-acting beta agonist, they can also take the steroid as well, okay? Or there are some inhalers now that have the low-dose ICS, which is a steroid, and the short-acting beta agonist combined in one inhaler. So it's either they take the inhaler with the ICS and also take that with short-acting beta agonist, or they take the one inhaler that contains both. Now, if the patient has symptoms most days or waking up at night once a week or more, or low lung function, GINA recommends the track 1 is preferred, low-dose ICS, which is low-dose steroid with that formoterol as a maintenance and as a reliever. Okay, so they are prescribed a steroid with formoterol, as a maintenance meaning like maybe twice a day, morning and night, and it can also be used as needed as a reliever medication inhaler. Now, track 2 will be low dose steroid with a long-acting beta agonist and as needed short-acting beta agonist. And if you have a patient that experiences symptoms daily, they're waking up at night or, once a week or more, so it's like daily struggle with asthma, then GINA recommends track 1 will be medium dose. So it's going from low dose steroid with formoterol as a maintenance and as a reliever, okay? And then track 2 will be a medium to high dose steroid and LABA and long-acting beta agonist, and also a short-acting beta agonist. And maybe they can also have a short course of oral steroids as well, okay? It depends on the severity of their illness or the disease at that time. So this is from 12 and above. Now, from 6 years and 11 years, if the patient is experiencing symptoms less than 2 days a week, they can be prescribed or they can take a low dose steroid whenever they take the rescue inhalers. If the symptoms is 2 to 5 days a week, they can use or prescribe daily, low dose steroid plus as needed rescue inhaler. The short acting beta agonist. If the symptoms is most days or waking up at night at least once a week or more, then they can use or they can be prescribed a low dose steroid and long-acting beta agonist or a medium dose steroid and as needed short-acting beta agonist. And as well, so it depends on the severity of the problem, of the illness, of the attack. If the symptom is now most days, they are waking up at night once or more a week with a low lung function, then, it is on top of, they are getting the ICS, the steroid, plus the long-acting beta agonist, and they're getting short-acting beta agonist as well. But you also have to refer them to expert advice, right? So now for children younger than 5, so 5 years and younger, for them, the reliever here is short-acting beta agonist. Is the reliever medication. Now, based on the severity of their problem, their symptoms actually, they can be prescribed low dose ICS, and step up from there. And also maybe, refer to a specialist. It's always good to refer to a specialist, a pulmonologist, right? But this young people, 5 and younger, they are not really, you can't expect them to do what's it called? Spirometry, spirometry, right? Pulmonary function test. So, and they usually have like infections and cold and flu at that time, at that age, right? And they also experience all the symptoms of asthma. So they are given the short-acting beta agonist to use. It could be it's always as needed, right? So, and the warning here by Gina, I said, if prescribing the LTRA, which is the leukotriene receptor antagonist, that's a type of medication as well. If the children of that age are prescribed that, then, advise the parents and caregivers about the risk of neuropsychiatric adverse effects, okay? So, across all age spectrum, Gina calls us to, you always assess the patient. We always have to adjust and we'll review. So it's like a continuous process, right? Assess the patient, adjust, and review. So, and it's also important that we as healthcare practitioners, we also assess the inhaler adherence and techniques of every patient. Per Gina, up to 80% of patients have poor inhaler technique. And I can see that. I'm sure a lot of us that work with asthma patients can, you've seen that, you've noticed that as well. The patients are really, a lot of them actually, even in the clinic that I run, a lot of them are very confident that they know how to use their inhalers. They can, they will say 100% confident I can use my inhalers. But when you tell them to show you how to use their inhalers, then they realize, and you teach them, they realize, oh, I've been doing it wrong for these years. So as healthcare practitioners, I don't want us to just rely on just one time teaching or education on inhaler technique. It's a constant thing. It's a reinforcement. Because if it's something that they have been doing for years, this wrong for years, it will take time to adjust, to unlearn, and to relearn the right way to use these inhalers. So in all spectrum, regardless, we are all supposed to assess the adherence and the techniques of our patients. So I wanted to kind of touch on, how these medications work so that we can really know, get to understand the importance of what medications and inhalers people with asthma need. So the bronchodilators, which are there's a short-acting beta agonist and there's a long-acting. The short-acting ones would be like the albuterol, levoalbuterol, salmeterol. Long-acting would be, they last longer, like the formoterol, formoterol, right, and salmeterol. So these bronchodilators relax the muscles in the airways. They relax the muscles. They do not reduce inflammation. Now, inhaled corticosteroids, which is the ICS, those ones decrease airway inflammation. The steroids decrease the inflammation. Anticholinergics would be like there's a short-acting and there's a long-acting anticholinergics. These thing, these two, so the first two are the primary ones, the bronchodilators and the inhaled corticosteroids. Now, these ones are now the add-ons, right? The third one and the fourth one, the anticholinergics and the leukotriene modifiers. They work, we say that, they work from the back door, while the first two work from the front, right? What that means is they indirectly reduce inflammation or prevent constriction. While bronchodilators and corticosteroids directly relax the muscle or decrease inflammation, anticholinergic will block. What it does, it will block the action of that acetylcholine. Acetylcholine causes constriction. So when they give the anticholinergic, it blocks the action of that acetylcholine so that it does not constrict or cause constriction. Now, the leukotriene modifiers will block the leukotriene receptors, thereby reducing inflammation. The leukotriene will cause, inflammation when it's released. So these medications block the pores where they, that cause the inflammation. So, but the problem here is that many patients and even healthcare professionals, either due to lack of knowledge or various challenges, are not up to date with these recent GINA guidelines. As a result, there is still over-reliance on short-acting beta agonists and on the use of inhaled corticosteroids. So again, steroids decrease the inflammation. Short-acting beta agonist does not decrease inflammation. What it does is to relax the muscles. But you see a lot of patients prescribed only the short-acting beta agonist. The main problem and the major problem with asthma is inflammation. There's always a chronic inflammation, like underlying inflammation in their airways. It's just waiting for something to trigger it, right? So I hear a lot of patients come in and say, oh, the only thing they use is their short-acting beta agonist, and they ended up in the emergency room. The short-acting beta agonist does its thing to relax the muscles, but it does not reduce inflammation. So it's actually like a pacifier, right? At some point, as you keep taking it, you might feel like it's not working anymore. And that's because maybe the airways are so inflamed at this point. So that is still a problem up to today. Now, for example, in 2021, the World Health Organization said that bronchodilators were available in public primary care facilities in half of the low to middle income countries. And the steroid, which is really needed, were available in only 1/3. Now, another example from Czechia, in their study, they conducted this in 3 African countries: South Africa, Cameroon, and Nigeria. And it shows that between 29.3% and 85.3% of patients diagnosed with asthma use short-acting beta agonists only. And only 12.6% to 551.9% use inhaled steroids. 44.8% individuals with severe asthma were not using inhaled steroids. The third example, this is from Masekela in 2022. This study was done in Uganda, Kenya, and South Africa. In Uganda, 33% had controlled asthma, 33% were taking inhaled controller medication, and 60% had greater than 1 exacerbation per year. In Kenya, only about 60% of people with asthma have asthma medications at home, and it was only limited to salbutamol and prednisolone. Okay, so South Africa, only 31.5% of children with asthma had well-controlled asthma, and 17.6% had been admitted to the hospital in previous years. Now, what are the challenges that of asthma management? So this is in comparison with high-income countries and resource-limited countries. When it comes to GINA alignment, GINA alignment is partially implemented in high-income countries and rarely implemented in resource-limited. And ICS and Formodro, that is highly recommended, is readily available in highly income countries, but there are also people that cannot afford it based on insurance or cannot pay out of pocket. But it's unavailable in resource-limited countries. The use of short-acting beta agonists is common here despite guidelines, but it's still the primary treatment in resource-limited countries. Education and action plans is variable in high income countries and rare in resource limited countries. And then, key barriers would be non-adherence, health inequities. And then, of course, in resource limited countries, it will be cost, access, and lack of training. And challenges to global implementation of GINA guidelines. Access to diagnosis is readily available in developed country, but limited or inaccurate in resource-limited country. Medication access is limited or expensive or unavailable in resource-limited countries, but generally good, but underused in developed countries. And so there are so many challenges, facing either developed countries or resource-limited countries, right? But there's always one goal, whether you're in a developed country or a resource-limited country, the goal is to ensure optimal asthma control and improve patient outcome. That is the goal. And this is where empathy means patient care, right? When you have empathy, you are a better advocate for your patients, and that will lead to long-term asthma control. Okay. Now, I want to mention that May 6th is World Asthma Day. And GINA comes up with a theme every year. And the theme for this day is make inhaled treatments accessible for all. So we all have a role to play. So per GINA, they said, if you're a doctor here, allied healthcare professional like all of us, respiratory nursing, wherever you are and you're a healthcare professional, GINA calls on us to ensure that every person with asthma is prescribed evidence-based essential steroid, right? And then for policymakers, whoever is a policymaker in policy here or government, pharmaceutical industry, they said GINA calls to increase their awareness of the continued prevention of preventable morbidity and mortality associated with asthma. So what else can we do here? We can, this is like starting from tomorrow, whatever we can do, whenever you go to your workplace and you have patients with asthma, right? Ensure that they're making informed decisions. And this comes from patient education at bedside or in the community. Make sure they understand the difference between their inhalers and the triggers, correcting the common mistakes and inhaler techniques, that they have the asthma action plan, and peak flow meter is available. I know that the peak flow spacers might not be available or readily available in some countries, right? For now, whatever we can do for now, starting from tomorrow, we'll go ahead and do it, pending when we can advocate for better care and, more peak flow meters for monitoring. Then assess patients' health literacy. Health literacy is really important to assessing patients because, there are some patients that might not understand that or are not able to understand basic healthcare information. You can educate them from now till next year, they'll still not get it. And that's not because of, it could be a decline. It could be, because of maybe they did not have their education, right? So it's good to assess this, health literacy. Physician education is important as well, because a lot of times the patients usually go to non-pulmonologists or specialists. They might just go to a regular primary care physician, and some of them might not be up to date with the recent guidelines, right? So they are still going, recommending or prescribing this short-acting beta agonist alone, except there are challenges maybe, and, they are unable to, sorry. So we have to reconcile the inhaled medications using our respiratory therapy-driven protocol. If you have it where you work, I have it where I work, so it's really, it's really good for respiratory therapy. So that way you can reconcile patients' medications while they're in the hospital, and then advice on asthma biologics if they meet the criteria, and of course, advocacy. Now, this is a real life scenario. A 22-year-old patient was brought in by ambulance after being found unresponsive at home due to asthma exacerbation or attack. And this led to her, being intubated, and she was put on a breathing machine, and it left her with an anoxic brain injury. Then it was reported by her mom that she kept using her rescue inhaler, which was the albuterol that she had, until she felt like it was not working anymore. They called 911. However, by the time the help got there, she passed out and she became unresponsive. What was the problem here, right? The only inhaler she was using was the, albuterol. Again, I said, if they don't have a steroid that decreases the inflammation, they can be used. They'll feel relief with the albuterol, but at some point, it will not work anymore because the main problem, which is the inflammation, is not being treated. Okay. So this is another one, how to reconcile medications. A patient was admitted to the hospital with cardiac issues, but had a history of asthma. Then he was prescribed the every 4 hours nebulizer treatment of albuterol. And based on the assessments, he had a clear breath sounds. His home medication was Symbicort, which is a steroid and a long-acting beta agonist twice a day. And then he had albuterol as needed. There was no respiratory distress. Oxygen saturation was in high 90s on 2 liters oxygen. So the action that was taken for that patient was I added a Symbicort, which was his home regimen, right? And then made the peer albuterol as needed, right? So the next day, actually, now this is for physician education. This is how we can help. The next day, the order was changed back to what it was. So, it was changed back to short-acting beta agonist every 4 hours, and the Symbicort was actually discontinued. And the physician wrote, the physician wasn't a pulmonologist, she wrote, do not change the order because the patient has a history of asthma. So the thing is, having a history of asthma doesn't justify the every 4 hours treatment if the patient is stable. Now, if the patient is in an acute problem and needs it, of course, by all means, yes, right? Even every 2 hours, they're continuous. But this particular patient did not need it based on the, scenario. So, but the physician had to also be educated as well, right? So what I did was to write a note again, on the reasons why this patient needs to be on an inhaled steroid, because of the history of asthma. So I don't know if I'll finish. Patient, this one is another scenario of a patient, how to reconcile medication. It's just basically a patient that was getting a treatment every 4 hours of just a short-acting beta agonist every 4 hours. And based on the assessment, there was no indication for that, right? And this patient clearly has steroid and long-acting beta agonist at home that she uses at home and as needed albuterol treatment. So just to reconcile the medication to match what the patient was using at home, and definitely make sure that this patient with asthma is also getting a steroid, okay? So patient education at bedside is something like this. A patient might, insist, even though there are, no issues, they are stable, clear breath sounds, not in any asthma attack at all, but they insist on using that, a short-acting beta agonist every 4 hours, if possible, every 3 hours, because they just want it, right? But they have the maintenance, which is a steroid with a long-acting beta agonist, but they don't want to use it, or they said it doesn't work well for them. How do you help a patient like that? You educate the patient on the importance of using a steroid and what the steroid does, and what the importance of keeping the short-acting beta agonist as needed. And also, if the patient feels like the inhaler that they have, which is the controller inhaler, is not working, then you refer them back to the prescriber, the pulmonologist that ordered it, so they can work around it and find one that works for them. And so this is what an asthma action plan looks like, which we can all actually, if you can actually go to Google it and print it out and give it to your patients. Asthma action plan is used to guide patients to manage asthma, right? It has the green lights, green zone, yellow zone, red zone. It's very important, and it works hand in hand with the peak flow, really. The peak flow is used to monitor when there's a flare up coming up, right? Sometimes the patients will even notice a decline in their peak flow meter before they actually start experiencing symptoms. So it's good that they monitor this every day if they have it. If they don't, well, it's just to keep up with monitoring the symptoms and the home assessment and everything. But an asthma action plan you can print out and you can give it to your patients so they can actually take it to their doctors, their physician's appointment. The physician has to complete it with them. Okay, and telling them this is what you do when you're in the green zone, when everything is okay, normal, you're not experiencing any symptom, or when you feel like you're starting to experience something and you're in the maybe yellow zone, this is what you do, this is what you take. And when you feel like, okay, you're really not looking good, take this, but you have to, go to the emergency room right away. These are some of the common mistakes that patients make when it comes to inhaler use. I usually show them this picture, and once I show it to them, they're like, wow, I didn't know. I'll start to use a spacer. So when the inhaler goes directly in the mouth, most of the medications are deposited at the back of the throat. A little bit goes to the lungs. But with the spacer, when that space is created between the inhaler and the mouth, it makes for better deposition in the lungs. So most of the medications will go in the lungs where it is needed. And then the advice on biologics, biologics is a shot, asthma shot that is given once a month, but they have to meet certain criteria to, that's if you're using insurance, right, to cover that, for insurance to cover it, or even to get biologics, right? So some of the criteria are listed, here. You've been going to the emergency room, or you've gone at least once a year due to asthma. You're having to use your rescue inhaler often. Waking up at night at least twice a month due to asthma, right? And then being prescribed oral steroids. So advocacy will continue to advocate for our patients on policy change, educating health professionals, and trying to influence policymakers on the need to improve access to care and adherence barriers. And this is the reason, and also the need for respiratory professionals. And that's the reason why ARCA Respiratory Care, Africa Respiratory Care Association is pushing for, implementation of the respiratory therapy profession in Africa, right? So, and for patients that might be here, or parents or caregivers, how do you know that asthma is getting worse? When you start to experience some of those symptoms that we mentioned earlier, like shortness of breath, wheezing, chest tightness, all of those, right? The first thing you want to do is to stay away from the trigger if you know what triggered it. So it's always good to actually go to an allergy, do an allergy test so you can know what is you're allergic to, what food that you might be sensitive to, because these things can trigger asthma. So if you know what triggered it, move away from that and try to take your inhaler or rescue inhaler right away and try to keep calm, right? But if you've used this, if the inhaler is not, or the treatment doesn't seem like it's working and you're getting worse, bluish discoloration on your fingernails, which is called cyanosis, or you're speaking in words, not really sentences anymore, you're unable to speak, you're using your muscle, you're really struggling to breathe. Now that's the time to go to the emergency room, call 911 if you're here, or, find help, take somebody to take you to the emergency room. So in summary, there's always an underlying inflammation in an asthmatic airway. And what decreases the inflammation is a steroid, inhaled corticosteroid is needed to reduce the inflammation. And again, if the only inhaler that you use contains a steroid, this is what Gina said, the risk of asthma attack is high because the main problem is not being treated, which is the inflammation. Okay. So this is advice that we give patients or parents and caregivers. We teach them how to identify early onset of asthma attack and what to do. Tell them about asthma action plan. They can, you can print it out, you can give it to them. That's also part of advocacy, give it to or have them printed out and take it to their doctor. Advise them to get a specialist, a pulmonologist that can manage that asthma well. How to recognize signs of cyanosis, the bluish discoloration. Peak flow meter is important. And then spacers. If they can actually afford to buy it as well, it's on Amazon, things like that. They can also buy it, but it can, to help to monitor other asthma. A pulse oximeter, if they can afford it, if they can afford to have it, that's also good to monitor oxygen saturation, and advise them on allergy testing and teaching them breathing exercises as well. And also the home assessment is important. If they can afford to do this, I know a lot of places or a lot of people might not, but it's good to also tell them, wood carpet carries a lot of dust. It traps a lot of dust. So it's always recommended to change the wood or to tiles or to have this vacuum cleaner with HEPA filters. Animals with fur can increase the amount of dust in the house, or their furs, right? So check the house for things that can trigger the asthma, like mold, and change the filters if you have filters. Staying away from smoking, not only people smoking or you smoking, but also the environment, like the smoke from wood and things like that, right? If possible, we can wear a mask. For some people, it might be okay. And so the global asthma COPD outreach was birthed actually because of this, to improve the lives of individuals affected by asthma and COPD through global virtual and in-person healthcare worker, patient, and caregiver education and advocacy. So what we believe here is that no matter everyone, no matter the geographical location and socioeconomic status, should be knowledgeable about the disease and have access resources available to thrive and breathe easy. Okay, so global asthma outreach is led by respiratory therapists. And I wanted to also touch on the ARCA mission as well. ARCA is committed to uniting respiratory therapists and healthcare professionals across Africa to foster excellence in respiratory therapy, to ensure that every individual in Africa has access to high-quality respiratory care. All this is geared towards reducing the mortality and morbidity caused by chronic respiratory diseases, which asthma is one of them. So I've come to the end of the slides, but if you want to join and partner with ARCA, the contact is there. And for global asthma and COPD outreach, this wherever you are, any country at all, it doesn't matter. If you have access to virtual internet, we can have an asthma education, and also it can be in person as well once we get the way to get there. But GACO, in collaboration with ARCA, is dedicated to providing free virtual and in-person asthma and COPD education by respiratory therapists anywhere in the world. So I hope that I have empowered you enough to teach patients how to fish. And thank you very much. And I'm welcome to, you're welcome to ask questions. Now, I will leave the slide here. This is a survey that we are collecting from Africa Respiratory Care Association, and is meant to, it's meant for us to, this is not for respiratory therapists, this is for any other profession. It can also be school administrators. If you feel and you know that every country in Africa should have respiratory therapists, it's good to, we encourage you to ask you to fill out this 2-minute survey. Okay, scan the QR code and complete it. And thank you very much for your time. I appreciate you all.
Thank you so much, Dr. Ngozi Ibe. Please, can you hear me?
Yes, I can hear you.
Okay, so before I go to the Q&A session, you can see the QR code over there. It's in French and in English. So the French one is the light blue colored one, and then the English one is the dark colored one. So if English is your language, kindly scan the QR code for English. And if you're listening and you can interpret or spread it in French, you can use the other one. This is to validate the need for respiratory therapy across the Africa continent. So wherever you are participating from, kindly share this questionnaire across. This is not for respiratory therapists to validate themselves, but we want you to validate or fill in and then show the need for respiratory therapy in your country. Thank you very much, Dr. Ngozi Ibe, for this insightful session. Now we are going to our Q&A. Now from Harrison, he says, will this training certificate be presented? Okay, so Harrison, if you need certificate for this, kindly contact Africa Respiratory Care Association from the info@africarespiratorycare.org, info@africarespiratorycare.org. I will put that on the screen towards the end if you need a certificate for that. That is if you want to use it for to gain a point for CPD, then that is it. And then an anonymous question. This information is great. Please, can the recording be made available? Okay, so kindly note that for now, Africa Respiratory Care Association doesn't give out the recording yet. It will be on the website later after, these webinar sessions. Okay, so that people can actually visit. You go to the event session later, it will be announced when it is posted so that you can actually participate from there. Thank you very much. Another question from Tiberius. Do the track I apply to stable asthma? So I want to find out, and this is to Dr. Ngozi Ibe. It looks like, how do I track how to apply or how to apply a stable asthma, or how does it attract the whole stability for the asthma condition?
I'm not sure.
Or how can he notice that the asthma is becoming stable or is working out, maybe the condition is subsiding? That is what he's trying to ask.
When you don't have any symptoms, when you don't experience any symptoms, remember that is the goal. The goal is to go as long as possible without any symptoms, no exacerbations, no attack, and even with the lowest inhaled steroid, the lowest dose of steroid. And yeah, so that's how you know that you're stable.
All right, from Anytime, he says, what do you think about using an oral antioxidant supplement as an adjunct therapy? Would it be beneficial?
Now, there are some questions that will go to the physician, to the doctor, but what's the antioxidant or inhaled? Ask that question again.
It said, what do you think about using an oral antioxidant supplement as an adjunct therapy?
So what recommendations that I put there based on GINA is based on guidelines that we use. It didn't mention antioxidants, but inhaled steroid is what you need, what the patients need for start the inhaled steroid as needed, and inhaled steroid with formoterol as needed, but not the antioxidant. So I'm not going to say that, recommend anything else because it's not proven. But based on the guidelines, whatever you saw on the slide is how we manage asthma with the inhaled steroid and formoterol and the short-acting beta agonist, and then the other add-ons.
Okay, and then from Saeed Mohammed Osman, he says, I have two questions and comments. What is the blood test related to asthma diagnosis? That's the first question.
What is the question? Sorry.
What is the blood test related?
Blood test.
Yes, maybe when a person does maybe a full blood count, what the person wants to know, what is the blood test? Or perhaps what I understand from this question is there a blood test to diagnose for asthma?
So asthma can be diagnosed with doing pulmonary function tests, right? Spirometry. Also they can do a blood test to check the count of the white blood cell, which is eosinophil. That will show, what it shows. It doesn't really diagnose asthma, but it will show if there's increased inflammation. So they can do blood tests for that. They can also do like a bronchial, the provocation testing for those that are coughing a lot. There's so much noise in the background.
My name is Mac. My
What's
favorite
up,
local is playing today.
Yeah,
We
it's too
expecting
much noise. Anyway, so yeah, the blood test that can be done will be the level of eosinophil, but it is not for diagnosis of asthma, but it will show, it will lead to, to prove that, there's increased inflammation in the airway. Okay. What's the next question, Ms. Dorothy?
Please, can you hear me?
I can, but it's just noise in your background.
Oh, sorry.
Go ahead, ask the next question.
Okay, so what is the relationship between asthma and blood pressure? And my comment is about the color of the background of the of some slides. Well, the main question, what is the relationship between asthma and blood pressure?
And blood pressure? Asthma and blood pressure. So asthma is a disease of the airway, right? Asthma is a chronic disease of airway, is reversible, but blood pressure is, the pressure of the blood, how the blood that is pumped in your blood in your body. We check the blood pressure to check the systolic and the diastolic pressure to see how well your body is pumping blood, or your heart is pumping the blood to the body. Okay. So, but asthma is just a disease of the airway that causes inflammation, bronchoconstriction, mucus production. I hope I answered the question. But there's a big difference.
So let's move on to the next question, please. Okay, so apart from reducing inflammation, is there a synergy role or a synergistic role of high dose systemic corticosteroid on SABA during
somebody is talking, so it's making a little bit noise.
It's noisy, yeah. Ms. Dorothy, I think you're in an area with
you can use an earpiece. Use an earpiece.
Are you talking to me, right?
Please, is it better now?
Yes.
Yes, somebody was talking. Yes.
It's better
Yes.
now.
Yes.
All right, thank you. Yes.
Sorry for the echoes behind me. Sorry, I'm in a noisy place. Sorry.
No problem.
And so the noise was coming from the coordinator herself. Sorry. Okay, so I was asking a question. Is if a patient has an asthma attack and is not with his or her rescue inhaler, what can be done as a first aid to help the patient before getting access to an inhaler?
Well, so first of all, it's important that we tell our patients to carry their inhalers around, because they don't know when they'll run into crisis. Now, if they don't have their inhaler, you have to call help for them. You have to call help. You have to call somebody that will, if it's here, we'll call 911. I don't know if there's any home remedies that you can do while you call, but you have to call, especially if they are really symptomatic. That's the time to call, go to the nearest emergency room right away, as soon as possible. But if it's not symptomatic, they forgot it's not symptomatic, definitely you still have to call the doctor. You still have to see the doctor for an inhaler, or go back and get the inhaler if they have it or forgot it somewhere, things like that. But if it's symptomatic, the first thing you want to do is to find help, get help right away.
Okay. Another question. There is a traditional practice where people burn certain herbs and cover themselves with the smoke, which can trigger asthma. However, many people are unwilling to give up this habit. Since removing triggers is an important part of asthma management, how can we help someone who is constantly exposed to such triggers?
Yeah, it's also through education. We have to educate them. We have to tell them, in most countries as well, the stigma is still very strong there, and people try to, do it their way. I know there are some patients that, have their remedies, their home remedies and things that they do, and it works for them. That's fine. But it comes through education. We cannot the way we can indirectly control the environment is through advocacy. We have to keep advocating for policies that will help to, control and limit some of these exposures to triggers. But the person that does it in the home or maybe exposed to smoke is education. You have to educate them on the importance of, if possible, having somebody else do those things for them, or staying away from them, or if they can wear a mask, something but they have to stay away from that if it triggers their asthma. If they have asthma and it triggers it. Right? I'm sure they all want to live. We all want to live. So it's education and the importance of staying away from triggers and how smoke can trigger asthma. For some people, everybody's different. Smoke might trigger it for one person, but not for the other. So, but it's through education, empowerment, so they can be empowered as well and know.
The next question is, what about exercise-induced asthma? Is it the same treatment?
Yes, it's the same treatment. So asthma is asthma, all those treatments recommended by Gina. Patients, anybody with asthma should have inhaled steroid and a short-acting beta agonist as needed. Now, exercise-induced asthma, sometimes those patients might have the asthma attack when they do like a physical activity. It can be walking. In that asthma action plan, the physician can put there, maybe if you're having an exercise-induced asthma, you can use your inhaler before doing that activity, or sometimes you can use it after as well. So that can be contained it's contained in the asthma action plan. Use it before and or after you exercise or after physical activity, but it's the same treatment for all. And for those people, might be some patients that do not have, I mentioned this before, that might have mild asthma. So maybe just only when they exercise, only that. They still need to have their inhalers with them wherever they go, especially if they're going to exercise. They always need that rescue inhaler, and they always need that inhaled steroid with formoterol. The one with the formoterol, not all the inhaled steroid can be used as needed, but the ones that contains formoterol can be used as needed.
Okay, thank you. And from Lisa, I said, is salbutamol inhaler alone advisable for during asthma attack, or should have another type for a 9-year-old?
So I did put on there for 9 years, I mentioned 6 to 11. So salbutamol is a beta agonist. It does not treat inflammation. Now, but for the recommendation for guideline is from 6 to 11 years. And it showed that that should be prescribed an inhaled steroid with short-acting beta agonist. So salbutamol alone is not treating the inflammation, remember. So it's not, for Gina, it's not recommended just alone for the treatment of asthma. You can have it, they can have it, but they also need the steroid.
Okay. And then someone is asking a question about the Global Asthma COPD Initiative. It says, can anyone interested in the GACO mission also join?
Absolutely. Anyone is for everyone, is for anyone, because it's a global movement. It's for every country. And the goal, again, is to make sure that people with asthma and COPD are breathing okay, that they have their resources, that they have this inhaled medication. So it will be advocacy, advocacy to policymakers to make these inhalers available. So yes, everyone and anyone can join. And if you're in any country in Africa or anywhere at all, we will also plan to come over there to the countries, with funding, and also empower train the trainers so if you're there locally, then you can help to train the others and the patients. So that's the goal. Yes.
Okay, so for this particular question, I will also say that if you want more information on how to join, you can also contact the Africa Respiratory Care Association. We will lead you to the GACO so that you can be a part of it. Okay, so and then there is a contact information over here for you to also join. You can contact her directly at ngoziibe@gmail.com. Okay, so the next question says, do you advise an asthma patient doing the treadmill or playing football?
A patient with asthma can do whatever they need to do. They can exercise if they, so people, yes, so the exercise-induced asthma is not for everybody. It could be for, some people. It's recommended, physical activity is recommended, but you also come, talk to your physician. The physician has to play a big role, in the management of that, to really instruct them on what to take. But, again, those inhalers are needed. They should be available, So, but the goal of GINA is to have, for people with asthma to do whatever it is that they want to do with the least and the longest, go the longest without having any symptoms of asthma. So the first thing is to make sure that those inhalers are available for anyone and they can use it when they need it, and especially if they're physical activity, football or anything.
Okay, thank you. And an anonymous question says, hi, I am from Somalia. I'm very happy to attend this meeting, and it was very helpful and well prepared. So this is to the presenter. And then the question is, those who have chronic asthma, does the the person said Montelukast drug help instead of short-acting, long-acting bronchodilators? So the person wants to know.
Montelukast can be added. That's an add-on. It's an add-on to, the other inhalers. So the primary medications will be the steroid and the bronchodilators. But leukotriene and Montelukast, those ones can be add-ons. So the physician can decide to add that on, but it depends on the severity of that asthma. It depends. So if it's a mild asthma, there's no need to add on. But if it's somebody that experiences these symptoms daily or, more often, then the physician can decide to add on that Montelukast.
Okay, so still on the Global Asthma COPD initiative, an anonymous question says, I saw GACO on the ARCA website. When I clicked on it, nothing opened for me to join. Okay, so to answer this question, kindly reach out to Dr. Ngozi Ibe or send us direct information to info@africaresp.org. When you send it to us, we would help you join from wherever you are connecting from. We'll give you the appropriate place to join. Thank you. And then as well, you can also reach out to Dr. Ngozi Ibe as she posted her information on the screen. So Dr. Ngozi, you can still repeat that so that the person can contact you directly. You can WhatsApp her if you are not in the US. You can WhatsApp her or can send her an email or go to info@africaresp.org. That way we can easily reach out to you to help you. The next question is, salbutamol inhaler alone advisable during asthma attack, or should I have another type? Okay, so this question has been answered for the 9-year-old child. Then they said, are there breathing techniques that can help relieve the symptoms a bit? This is from an anonymous question.
It's a breathing exercise that I usually teach my patients, especially, with shortness of breath. And it's for everybody, really. I do it myself, right? When you breathe in, so you breathe in, encourage your patients to breathe in through the nose, and out through the mouth. But out through the mouth should be longer than the breathing in. So you breathing in through your nose, 1, 2, and you purse your lip like this and breathe out slowly until you get the air out. You're breathing out slowly so that they can create that back pressure and keep the airways open. So in through the nose, out through the mouth with pursed lip breathing, and longer will be good. It helps to calm the person down and relieve some shortness of breath.
Okay. So, and then anonymous question again says, this is a suggestion, not really a question. It said a good number of asthma patients do not know how to use the inhaler correctly. Can a kind of inhaler technique video site be recommended that patients could watch at the comfort of their home? And if there is no site to get videos from, ARCA could help contribute to this initiative. Okay, so this is to ARCA. So it is well noted. ARCA will put something together. Since it is a global asthma month or week, we would put some videos together so that you can actually observe how it is done, as well as the breathing technique that Dr. Ngozi Ibe was demonstrating to you. So we'll put that together. So watch out for that. And please, if you haven't joined the Africa Respiratory Care Association, kindly go to www.africares.org. That way, when we share resources like that, you would be able to have it so that you can share to your community and families. Any more questions from this side? Okay, so I can't see any questions coming up. So on this note, I want to say a big thank you to you all for participating. And thank you to Dr. Ngozi Ibe for making time, putting this together and making it very educative for us. We have actually learned a lot. So Zopec Medical, as I said, they are a company that produces the world's smallest battery that supports mobility. So let's say in Africa, and this is a UPS battery. In Africa, we have uninterrupted power supply or interrupted power supplies, every day. And this system is an uninterrupted power supply that ensures that the medical equipment that you are using to take care of the patient doesn't go off, so that you can continue your care, or you want to transport the patient from one unit to another, or perhaps patient has undergone surgery and is receiving treatment, but you want to start working the patient early so that the patient can recover on time. This system has come in to help support the devices that you are using so that there is a continuum of care. Now, if you're in Africa and you want to purchase these batteries, or you are a healthcare administrator or procurement officer who wants to get this for your hospital, you can contact Zopec Medical from their country rep in South Africa. That is +2766 233 2941. And then the name is JC Tallboy, so jc@pulmonaire.coza. Or you can contact the africaresp.org. So when you contact africaresp.org or you go on the website, you will see much information about it. You can directly go on their website and then you make your request. But if you also have any special concern you want to ask about these batteries and what they do, you can specifically WhatsApp me on +233 54 923 9673. And on this note, I would want to say a big thank you. And as Dr. Ngozi Ibe said, the survey that she posted, we want you all to share it. We want to validate the need for respiratory therapy across the continent of Africa. And you can also play a key role in making this vision a reality. So on that note, I want to say it's time for Africa. Let's make Africa great and strong in healthcare. Thank you all so much. Thank you. It's bye-bye from now.
Bye.
It's time for Africa. Let's rise and breathe as one. With the African Respiratory Care Association, our journey's just begun. Promoting excellence, our mission strong and true. For every breath we take, ARCA's here for you. We unite therapists across the African land, empowering breathing with a helping hand. Advancing education and setting standards high. For every life we touch, ARCA's standing by. It's time for Africa, let's rise and breathe as one. With the African Respiratory Care Association, our journey's just begun. Promoting excellence, our mission strong and true. For every breath we take, ARCA's here for you. We advocate, we educate with passion and with pride. In every nation's heart, ARCA's on your side. From policy to practice, we lead the way ahead. We're global collaboration. Our mission's widespread. It's time for Africa. Let's rise and breathe as one. With the Africa Respiratory Care Association, our journey's just begun, promoting excellence. Our mission strong and true. For every breath we take, ARCA's here for you. Together we will grow, our goals within our sight. With ARCA's guiding light, the future's looking bright. It's time for Africa. Let's make our vision real. The Africa Respiratory Care Association, here to heal.